Hi, my name is Mauricio. I'm with the Arizona State University Reach Institute. And the Reach Institute was founded about 4 years ago, and the whole purpose is to bridge the science to practice gap. We have evidence-based interventions, but the problem is that when we try to put these in real-world settings, they don't work. So that is the emphasis of the Reach Institute. And I'm going to talk with you about the family checkup today. Can you all hear me okay? Talk with you about the family checkup today, which is one of the interventions at the Reach Institute. It's an ecological family-centered approach to child mental health care. So that means that we believe that it's important to empower the caregivers with the tools and resources and supports they need to be the effective parents that they want to be, they can be, and to be the agents of change in their children's lives. So the family checkup's brief. It's a preventative intervention for families. There's a model for 2 to 5, but also the model also extends to age 17. The focus is really on improving maternal well-being and positive parenting and parent-child relationships and family dynamics. There's an important emphasis on the idea that the caregiver it's important to nurture the caregiver and take care of the caregiver and make sure that she has the support she needs to be the effective parent she wants to be. The intervention has had effects on a broad range of child outcomes, and there's more than 30 years of research that shows the intervention works. So the process is such that the providers, which are practitioners, or the folks that do the intervention, they integrate assessment with motivational interviewing. They tailor intervention goals and dosage to meet the unique needs of every family. And it's important that they use collaborative and strengths-based approaches. The intervention is well suited for what we call a health maintenance model, the idea that we believe periodic family checkups are key and that they can be integrated into routine care, such as well-child visits. So the intervention is based on child development theory and corresponding extensive research that supports these theories. So ecological theory and research is an important framework for the model. So is the idea that it's important to really take care of the caregiver, and the caregiver needs emotional support and well-being to be that parent that she wants to be or that he wants to be. That positive reinforcement is an effective behavior change strategy, in that telling kids what they are doing well is more effective than telling them what not to do or what they're not doing well. That parent emotion regulation is also an important factor in the equation, that if we want parents to reduce harsh parenting and to reduce child maltreatment, that it's really important that they learn how to regulate their own emotions and they can model that for their children. We also focus a lot on motivational interviewing. It is an effective process in supporting long-term behavior change. The idea that our training really focuses on training providers not to tell parents what to do, but to kind of work with them to identify what is it that they want to do and that they think they can do. Our model is such that there are 2 phases. The first phase has 3 components: the interview, the assessment, and the feedback session. The interview is really different from a standard intake, and the focus is really on identifying, we call it the get to know you interview. It's really about getting to know the parent and the family and what is it they want to change, what are their strengths, and how can they leverage these strengths to create that change. The assessment is very ecological in nature. An important emphasis of the model is the idea that the child is embedded in several ecologies, several contexts, and it's important to understand how all of those play a role in influencing family well-being, caregiver well-being, and child behavior. The assessment involves both parent-child interactions and observations of those interactions, as well as questionnaires that can be self-report, teacher report, or other report. The feedback session is where all this information is really compiled. The idea is that the provider is trained to share with the parent what they have learned from the parent about their family and about them, and to use this information to work collaboratively to set some intervention targets or goals. An important part of this step is readiness, because we know that if goals exceed the capacity of what a parent is ready for, then they're not going to be effective and won't feel efficacious in creating change. So some follow-up services. The idea is that the feedback session would identify intervention targets and services that link to those targets. So an important follow-up service is the idea that, again, it's important to support that primary caregiver. And it's important to offer resources that will help the caregiver help the caregiver feel supported and well enough to feel that she can do the work she needs to do. Also, an important mechanism of change is the idea that it's important to work with parents so that they learn or can use positive parenting strategies. We have a curriculum that ties well into the model. It's called the Everyday Parenting, and it ties well into the model because it's modular. The way it was evaluated in trials is as a modular approach, meaning although there are several sessions, several domains, the provider works with the parent to identify, well, which domain do you want to work on? What do you think you need to strengthen? What do you think would be important for your family? And also, it can be used such that you could do one session. If the parent is only ready for one session, that's all you would do. It's also important to link parents with community resources and supports. We know that if there's food insecurity, housing insecurity, it's really hard to, if some of those basic needs are met, it's really hard to focus on some higher order change. So an important part of the model is really connecting the parent with those resources and supports and kind of using a case management framework to do that. So I was asked to talk a little bit about health equity, so I want to say a little bit about parent engagement. One thing we've learned a lot from both practice and research is that if you build it, they will not come or may not come or likely not to come. And that, I think that's a big issue in health equity, in that we also know that the folks who usually don't engage are those who could benefit from interventions the most. And the family checkup is actually a little bit different in that way, in that our research has shown high levels of engagement in follow-up services. Approximately 70% of the families that initiated a checkup actually went on to do some follow-up services, and up to 4 sessions. We also know that we have the highest engagement among the highest risk families, and that the intervention is effective for all families, but most effective for high-risk families. We also know from research that the intervention bridges high-need families with other services. So if you recall, I was talking about the importance of addressing food insecurity and housing insecurity. So families who participated in the family checkup were more likely to be connected and maintain connected to resources that were going to address those issues. Also, in terms of health equity, the intervention is it's accessed around family needs and service utilization patterns. So it can be implemented anywhere. It can be implemented in primary care, schools, WIC, child welfare, child delivery centers. So it's very malleable in how it can be implemented and where. So I feel like that addresses reach, the capacity to reach more families. It's resource efficient. It engages in families only to the appropriate level of need and readiness. And it really empowers families as collaborators of change in the process. So, and I know I've said this before, but it's really an important piece of the model is that, and I think this is the idea of being user-centered and integrating community ideas and values has come up in this meeting today. And I think that's a really important part of our model, like the idea that parents, we're just facilitating parental change and that we're not telling them how to change. The intervention is really designed to be tailored to meet needs and preferences of families diverse in cultures, contexts, experiences, and opportunities. That's actually an important part of fidelity to the model, is that the interventionist or providers learn how to tailor it. So in terms of evaluations, the model's been evaluated with thousands of families in several trials in both urban and rural communities nationally and internationally, with culturally, socioeconomically diverse families. In many different settings. As I said, it can be implemented in many settings and has been evaluated in many settings. One of the interventions, one of the studies was actually in a real-world trial, so it was a community mental health done by real-world practitioners, some of which were paraprofessionals, and that study actually found that fidelity was comparable across both the clinicians or therapists and the paraprofessionals, and in fact, engagement was slightly higher for the paraprofessionals, which sort of makes sense, right? Also, these studies have been based on multi-method, multi-reporters, so independent observations, as well as self-report, as well as teacher reports. So there are several reporters in several different ways we've collected the data. So what is the impact? So we have found that the intervention has effects across multiple outcomes. It decreases maternal depression, and these effects were shown to be up to 5 years post-intervention. It reduces risk for child abuse and neglect. It reduces behavioral and emotional problems both at school and at home. At school, as reported by teachers. It improves the ability to regulate emotions for kiddos. It improves their academic performance and school readiness, and it also decreases their risk for obesity. I don't have a slide on adolescent outcomes because the focus has been on early childhood, but there's also a lot of evidence showing that the model, when implemented in middle childhood with kids that are 11 or 12, has pretty significant effects for late adolescence and early adulthood. So a lot of significant reductions in depression, in risk for suicidality, in arrests, juvenile behavior, substance use. And I can share more with anyone about that if they're interested. So the change mechanism in the model is the idea that if we can improve maternal well-being, and our studies have shown that the intervention actually does in fact improve maternal well-being, that caregivers are more likely to then use positive parenting strategies, relationships with their child, and their family more generally improve. And then that leads to improvements in outcomes. So a little bit about our implementation process. So I said I'm at the Reach Institute, so what we've been doing is scaling up or disseminating the model in real world practice. And we try to use a process where we try to translate the model to real world. So first we work with communities to decide, is the model a good fit? Are they committed to doing it? And then we kind of, if the decision is yes, we move on to assess capacity to implement, who would be the providers that would implement, and or who would be the best providers at the site to do that, and then we train. And then in implementation, we support fidelity. We have multiple options to do that. We try to work with a site that, based on their resources, based on their needs, what they would be able to do. And then we train the trainer, have the train the model. In terms of sustainability, we have ongoing collaboration to support fidelity, minimize drift, and try to integrate the model into their service delivery system more broadly. So one of the questions I was asked to talk about was how we use data currently and in terms of translation of the model. So, a lot of the research out there on implementation is based on studies, and what we've learned is that what happens in studies doesn't translate to real world. So we've really been trying to collect data from our sites in a low burden, a cost-efficient way to understand, well, what does work in practice and what do we need to do, and to have sort of some dynamic feedback loops to improve our processes. So we try to ask, one of the things we learned is that administrators may select the programs, but they don't really know if they're going to fit. So trying to engage providers in those preliminary discussions about, is this model a good fit for you? Who are the best providers? Who should be doing this? We're collecting data on that to try to understand some of those questions. We're trying to implement or systematically include mechanisms for incentivizing consultation for providers. And then also, how can we track outcomes across time from parents in a way that's feasible and in a way which will actually get us some data. And then also in terms of adaptations, we know that once the model's out there, a lot of the sites are actually adapting the model. So we try to work with sites to understand what are those adaptations, how can we inform them, and how can we support them, and how can we learn from them about what will work at other sites like these sites. So I was also asked to talk a little bit about barriers. And we have definitely encountered barriers, lots of them. I would say that quality assurance is a challenge in terms of assessing fidelity. We'll have folks, administrators who will call and say, we want the model, we got some funding, we have to use an evidence-based intervention, we found you guys, we like you, but we have to do this thing called fidelity. Do you know what that is? And yeah. But so they know that it's important, but a lot of times they don't really understand what it is or what goes into it, how to assess it. So I think that that presents a challenge. Provider turnover and resistance, I would say that we've experienced at least a 35% provider turnover rate. So we train folks, and within a year, probably a third of the folks we train leave. And then also folks are pretty resistant, particularly if you don't bring them in at the beginning of the process. They're not interested in implementing or being engaged. Adoption is a challenge. So site resources, again, related to how projects are done in research, that doesn't really translate to practice. So thinking about how do we adapt it so that the project can, or the intervention can actually fit the site resources. And I alluded to this a little bit already, but the idea that there's really a big disconnect between administrators who select the programs and the providers. So often we get to training and providers will talk about all the different ways that that might be a barrier to implementing in their sites. So we've learned that that's a challenge, a barrier. Billing structures. So a lot of the agencies we work with, community mental health, have quotas around billing and direct service, and there's no room for learning a new model. So it's really hard for them to take on a new model and implement a new model when the billing structures don't really allow for that. Also, there are pieces of the model, so if 30 minutes of preparation are required to implement it well with quality, particularly as a provider is learning the model, that's not really built in. Related to that is the issue that there are no administrative policies or changes in policies to promote uptake, allowing for time for consultation or certification or for learning the model. There are a lot of data collection challenges. Our data system doesn't match the data system of sites. Sites don't have the infrastructure to collect data. There are costs that sites do not want to incur for data collection, and of course there's burden for both user, parent user, or provider user. So there are definitely a lot of challenges to collecting data in real world. And then also when we often work with sites, a lot of them are already using some interventions that are not evidence-based. So the idea of kind of de-implementing those to work, so there's room for our intervention. So while there are barriers, there are also lots of opportunities, particularly related to the family checkup. As I mentioned, it's a health maintenance model, and in that way, it can have a large public health impact. It's intended to be used, in a brief way, but periodically. And again, it can be integrated into multiple service sectors, so to optimize reach, primary care, WIC, community agencies, religious institutions. It's also flexible in who delivers. Clinicians or therapists often are targeted as the interventionists or the providers, but it's also delivered by paraprofessionals. I'd say half of the folks we've trained to deliver the model are paraprofessionals. And then again, as I alluded to earlier as well, it links families to other evidence-based practices. So the idea that families who participate in the family checkup, if they need other resources, they're more likely to connect to those other resources and use them as a result. And then also the idea that some of our sites who have intake processes that are extensive, sometimes integrating another assessment can be a challenge. So we sometimes work with sites to try to integrate our assessment as the intake process, so feeling like that's an opportunity for implementation. And then also the idea of value-based care focused on outcomes. I think, this is not in Arizona, but I have colleagues in states who talk about how this has made it easier to implement the model because sites are focused on the outcomes and not so much the billable hours. So I think that makes a huge difference. Also, we are currently evaluating a model for 0 to 2 that has very promising results, and we hope will be available for dissemination soon. So in terms of change and political will, there's also a question I was asked to talk about, like the idea of what will facilitate dissemination related to systems change and political will. I think that the idea of linking the model to cost savings, or linking any intervention to cost savings in terms of broader productivity and other outcomes, I think tailor marketing to align with policymakers' personal and professional priorities. I think we heard that earlier today from some folks, and again, aligning billing structures with evidence-based practices. Workforce development, I think that another thing we encounter is that graduate programs, licensing boards often don't emphasize evidence-based programs. They don't learn about them in school. Licensing boards don't credit clinicians for training in them, and I think that there's a big disconnect there. And we've heard a little bit about this today from other folks, but the idea that it's really important to collaborate across sectors, having physical health and behavioral health be integrated, schools, and kind of knowing across all sectors what's going on in the child's life and the family's life. And then also, it seems that in some states, from some of the folks' conversations today, that there is a shift from treatment to prevention, but I think that that tends to be a barrier, in that I think in political will would need a shift from treatment to prevention. So thank you for your time. I'd like to acknowledge our funders, but also that this work is the result of many years of research and many collaborators. Dr. Elizabeth Stormshack at U of O, Dr. Danny Shaw at University of Pittsburgh, our team at REACH, but then also the developer of the program, Dr. Thomas Deshawn, who actually passed away this year. Thank you for your time.